Hi, my name is Chloe, and today on Antibiotic Answers, we are going to talk about the new medication Blue Gepa, also known as Gepotidacin. So first, what is Gepotidacin and what bacteria does it cover? Gepotidacin is a first in a new class of oral antibiotics. The FDA approved this medication on March 25th of 2025. It is currently indicated for the use in uncomplicated UTIs in females 12 years and older. The recommended dose is 1,500 milligrams by mouth twice a day for 5 days, and it is often recommended to take after a meal to reduce the possibility of GI upset. Some common adverse reactions that were found during studies and occurring in at least 1% of patients included GI upset, which might be diarrhea, nausea, abdominal pain, flatulence, vomiting, and soft stools, headache, dizziness, and vulvovaginal candidiasis. Gepotidacin is a bactericidal topoisomerase inhibiting antibiotic. This means that it works by selectively interacting with both topoisomerase 2 and topoisomerase 4. By inhibiting these specific enzymes, the medication disrupts bacterial DNA replication, effectively preventing the bacteria from replicating. This medication is effective against several uropathogens, including E. coli, Klebsiella pneumoniae, Citrobacter, Staphylococcus, and Enterococcus faecalis. Now, before using this medication, we should be aware of a few considerations. First, I want to touch on drug interactions. So, it is noted that we should try to avoid co-administration with strong CYP3A4 inhibitors, as they can increase drug levels. So, some examples might be azole antifungals, macrolides, and protease inhibitors. We should also avoid with strong CYP3A4 inducers, as it may decrease levels. So some examples might be some anticonvulsants like carbamazepine, phenytoin, and phenobarbital. Also, some examples might be St. John's wort or rifampin. It is also noted that we should avoid co-administration with drugs that are extensively metabolized by CYP3A4 and have a narrow therapeutic window. Some examples might be some immunosuppressants, such as cyclosporine or tacrolimus, and then also fentanyl. Another drug interaction listed was digoxin, just due to an increase in digoxin levels and possibility for toxicity. Another consideration that we should keep in mind is some special populations. So that could include patients with renal impairment. So we want to avoid use in patients with severe renal impairment, specifically with an eGFR that is less than 30. And then we also want to avoid in patients with severe hepatic impairment. Now that we know about this new medication, we can look at what the potential impact is. Uncomplicated UTIs are the most common infection in women currently. They impact up to 16 million women in the United States each year. Over half of all women are affected by an uncomplicated UTI in their lifetime, and approximately 30% of those suffer from at least one recurrent episode. Overall, new treatments are needed as the number of uncomplicated UTIs caused by drug-resistant bacteria are continuing to increase. This can result in higher treatment failure rates. Although gepotidacin would not yet be considered a first line, it may become a useful tool for bacteria that has adapted to be resistant to many of our existing therapies and for patients who continue to struggle with difficult to treat or reoccurring UTIs. Here are the sources I utilized for today's presentation, and thank you for taking the time to listen. If you have any further questions or concerns, please feel free to reach out to Emily Perry at the NDSU CAP Center. Her email is listed here.